Welcome everybody to Wound Care Gurus Facebook Live. We are excited to have everybody on here with us tonight. I know it's been a while, everybody, since we have been on. We took about a month off. Denise and myself did a little traveling. We've been also busy teaching the WCEI course all over the country. I was in Philly. I was up in Alaska for a couple of weeks. So we got away from up there as well too. Thing it's just been a crazy month, but we're excited that you guys are tuned in with us tonight. We've got an exciting program tonight. We've got a great guest, Dr. Patrick Marasco, who is the developer of a closed pulsed irrigation system, and he's going to be kind of sharing with you his background. He is the developer of the product, and we're just excited to have him on board with us this evening. So with that, I'm going to bring Dr. Marasco online here with us. So hang on just one second. There we go. Oh, hang on. We are having, what happened here? There we go. Dr. Marasco. Hey, how are you, sir? Welcome to Wound Care Gurus Live.
Thanks, Bill. It's great to be with you this evening.
Excellent, excellent. Well, we are grateful for you taking the time to be with us. We're excited to hear what you have to share about your product. I mean, I'm vaguely familiar with it. Obviously, I teach sharp debridement. Denise and I do all over the country. And part of our thing, we talk about, irrigation systems as an option for debridement. And yours is one of the examples that we list of products in that arena. So, but before we get into, the Pulse Care product, kind of could you tell my audience a little bit about yourself and your role at Pulse Care Medical?
Well, Bill, that's a great question because when you have a good beginning, usually that means a good ending. And we started this company probably 12 years ago. I was captivated with the negative pressure irrigation because I was chief resident in plastic surgery with Dr. Argenta when we created the wound vac at Wake Forest. And one of the things that was notable, even though it was a great tool, was that there was a lot of bacteria building up on these wounds,
Sure.
especially in the wound vac sponge. And I was trying to, rather than get something going on the wound vac, try to treat the wound primarily. And we found out that pulse lavage was excellent at doing so. The only drawback was it had to be done in the OR.
Okay. I get you. All right. So what's a little bit about your background? I mean, obviously, I know you're a physician. What's kind of your credentials and stuff?
Well, I was, at Johns Hopkins undergraduate, Boston University. I spent some time at a Harvard surgical laboratory in Boston. And of course, I'm back in Boston now. My general surgery was at Michigan State and then plastic surgery with Wake Forest. And that's really where the Wake Forest connection is where I got interested in wound healing. And
Okay.
it's fascinating because it was a way to combine some of my studies in sepsis and wound infections
Right.
with wound care. That's
Gotcha.
how it ended up.
Sure.
Yeah.
Excellent. That makes a lot of sense. So obviously, I believe, Pulse Care Medical is kind of your baby. Can you tell us a little bit about Pulse Care Medical and why you started the company?
It was just an idea where we thought we would be able to not take the patient to the OR, but bring the OR to the patient. So that was the beginning of our concept.
Okay.
And what we had to do was come up with an isolation collection system for the proven technique that everyone loves, which we call pulse lavage. And in the process, we transformed everything because we eliminated the suction, we eliminated touching the patient, and so we came up with closed pulse irrigation, and that's where we are today.
Oh, okay. Excellent.
Yeah.
Excellent. So
Yeah.
it sounds like kind of the main reason for the CPI system was, like you said, you wanted to bring the OR to the patient instead of having them dragging them to the OR. That makes a whole lot of sense. So I
Well,
guess,
remember,
Go
Yeah,
ahead.
remember 10 years ago, PDPM didn't even exist, but we had the vision that eventually it would just not be cost effective to take patients to the OR for debridement.
Sure. That makes sense.
Yeah.
That makes sense. I mean, yeah. I mean, unless you need an emergency or a really severe surgical debridement, going to the OR, you're right. I mean, it's cost prohibitive for just a lot of wounds. So, excellent.
Yeah.
So let me ask you this. So, what is the primary and secondary functions of your CPI product?
Well, as we were talking about, Bill, we were primarily concerned with safety. We knew that the effectiveness would be there because there were close to 20 years of research showing that hydro debridement was a great technique. It came out of the Vietnam War, and then it was explored and talked about frequently.
Okay.
So we knew we had effectiveness. It was all about safety, really, in the beginning.
Yep.
Yeah.
Okay. So I mean, I understand the primary function, of course, is debridement. But
Yeah.
on a physiological level, how would you say that your product helps heal, besides the obvious of just removing dead
Well,
tissue?
right. Pulse lavage is noted for removing necrotic tissue, bacteria, and foreign bodies. So that's the foundation of pulse lavage.
Sure.
What we were able to discover was that, and I believe we're the first company ever to discover that the hydromechanical forces actually target biofilm and do a great job at removing biofilm.
Sure. That makes a lot of
So,
sense. I
yeah,
mean,
so we're
I know
primarily
that Denise.
focused on biofilm right
Okay.
now.
Yeah, Denise and
Yeah.
I talk about, obviously managing biofilm is a very hot topic in wound care. And I think, as you and I could both agree, rarely can you actually physically see a biofilm. It's a microscopic organism, as you're not going to be able to see it. And so when people tell me that they're sharp debriding biofilm, I'm like, what are you sharp debriding if you can't see it? You know? And so and what we've always taught is, if you suspect it and you haven't done the confocal laser scanning microscope to actually confirm it, and so you're going on suspicion, our always approach is mechanical debridement, either scrub or high pressure irrigation to disrupt the film, because that way you have little trauma to the good tissue in case your biofilm actually doesn't really exist. You're not tearing up tissue for no reason, if that makes sense. So,
Well, Bill, I think you're spot on, and you gave a very, very good, concise explanation that you want to disrupt. Number one, you have to disrupt the biofilm because it's very, very good at attaching itself to the wound surface.
right,
Number two, so after disruption, you have to flush it away. You don't want to leave it there in the wound. Number three, you have to get all of the different surfaces of the wound targeted for biofilm removal. If you leave just a little bit of biofilm behind, it's going to regenerate.
sure,
That's
yep.
what biofilm does.
Yep.
Yeah. And
24 to
then you want
72
to do
hours is what I've read.
exactly 72, 10 hours. And all of us, we have to brush our teeth every day because there's biofilm on our mouth. But what we're talking about is this idea that you have to do all that removal, disrupt, and remove the biofilm from all the surfaces. And then you want to do it with selectivity, which is what you said. Preserve as much tissue
Right.
in the wound bed so you're not making the wound larger to make it cleaner.
Right. Excellent. Excellent. Well, we got a question that just came up already from one of our audience, and I think it's kind of pertinent to what you just talked about. And it's, does Pulse Lavage have a recommended PSI?
Okay, great question. And also, I just want to encourage the audience to submit more questions during this talk.
Good
Yes,
point.
the FDA has approved the maximum pressure for hydromechanical debridement in order to preserve this selectivity. the pressure is 15
Okay.
psi, pounds per square inch.
All right. So I'm assuming then that's what the typical PSI is. Yours adjustable on your
Yeah,
product?
yes, it's very much adjustable because during the course of the treatment, the operator, the provider has to interact with the patient. And if 15 is too much, you're able to deliver a lower pressure of 8 if needed,
Okay. Excellent.
just
And I,
just to get started. Yeah.
sure. All right. And I think you shared an image. I'm going to bring it up on the screen if you want to talk about it, because since we're on the topic of biofilm, this is something I think that you did. I'm going to just pop it up here.
Yes.
You want to kind of explain what happened here, what this image is showing to the audience?
Well, this is not my research, but it's research that we're really trying to replicate, and we're so far we've done very well with this. This was done at the United States Army Institute, and this is a model of a open traumatic wound with bioluminescent fluorescent bacteria, Pseudomonas, on the left, and with just one uh, pulsed irrigation treatment using 9 liters of normal saline, you can see that you can obtain a great amount of bacterial disruption and removal. Now, at the time of this experiment, they were not really understanding that the bacteria was a biofilm. But
Gotcha.
now that we look back on it, we really understand that this is a biofilm removal experiment.
Excellent, excellent. Yeah, I think that, I mean, that was just that photo, that image is just really, I mean, blatantly obvious that this product will significantly reduce your bioburden on the surface of the wound tremendously, which is an excellent thing. Now, a couple of questions that kind of go right along with what we've just been talking about. I had a question from the audience. What temperature of the solution is best for lavage?
Well, most patients love the warmer temperatures, so that would be about 87 degrees. If you're a physical therapist, which I know, Bill, you have some background in
Yep,
physical therapy,
just a little
you
bit.
can, yeah, you can take your 3-liter saline bag and place it onto a warmer for a few minutes before you do the treatment.
Okay.
But in general, the protocol is written for 87, 89 degrees Fahrenheit.
Okay.
Yeah, and it's very, very safe. Most of our elderly patients enjoy the warmth. Certainly, if you're going to treat a Raynaud's patient or autoimmune patient that has an open wound, you want to have that warm,
Sure.
vasodilating effect
Right. That
during
would
the
make
treatment.
sense.
Yeah.
Excellent. Excellent. Well, great. Let's move on. I got another question for you, and one that's going to tie in with one that came in from the audience already, but I want to ask my question first. And that is, what are the healthcare settings that the CPI system is being used?
Well, right now, it's really completely used across the healthcare continuum, but it starts primarily in long-term care,
Okay.
just because the length of stay in a hospital is very, very short. But in long-term care, most LTACs and subacute nursing facilities are using CPI right now. What the growing field of interest is using CPI in home care in conjunction with telemedicine or telewound care.
Oh,
And
okay.
so far, the early results show that it's very promising to have 3 or 4 CPI treatments per week in
Hmm.
home, followed by once a week telemedicine specialist looking at the wound.
Okay. So that kind of just lays into my question from the audience, from one of our nurses. She asked, can a nurse perform pulse lavage using your product?
Yes, definitely. It's something that nurses and physical therapists, OTs, can embrace as a technique. You do not need to have added qualifications in sharps debridement, which I know Bill is an expert in. But if you were working under Bill or alongside Bill, you would be able to do it even if you were not wound care certified
Okay.
or sharp certified.
Gotcha. Okay.
Yeah.
Excellent. So with that, we talked about healthcare settings. Are you seeing it used a lot in acute care at all? You didn't mention that, but I was just curious, is it being used in acute care much?
Well, certainly emergency rooms like it for this sort of injury that occurs when there's a motorcycle crash and this road rash. So they like to put this together and irrigate the wound with 6 liters of saline before the patient gets transported. So it's being used in the ER.
Okay.
Also, the military is using it in some of their field hospitals, and that's another conversation, and that's another evening we can have together.
Sure,
Yeah,
sure, sure, sure.
yeah,
I
yeah.
got another question from the audience because it's kind of going right along with it, which is great. We've got a lot of audience interaction tonight. Do you need to have any type of consent form signed like you would with sharp debridement to do to use the CPI for debridement?
Yes, not in general. We don't have to have a consent form because it's a no-touch, non-invasive technique, and that's the beauty of it. That really is one of the beauty of it. The patient, you don't need to get a legal guardian or proxy to sign a consent form. You can just have your physician order it, and you're all set to use the CPI.
All right, cool. Well,
Yes.
you just answered a question. Do we need a doctor's order? You just answered that. Have to have the doc order it. So now,
That's a great, yeah, that's a
in
great
the home
question.
care setting, is this something a PT can go out to the house and do debridements with? Is that it sound like? I mean, is that a logical approach?
Yes, PTs are definitely welcome in the home care setting. This is a great tool for PTs and nurses side by side. When it comes to PTs, I've learned a lot about that specialty. In fact, I teach classes at Northeastern University here in Boston and at Simmons College in the PT classes, and
Oh, awesome.
we try to promote wound care, but in the process we introduce this great tool because sometimes if you have the technology, then the interest will grow around a certain technology, and I
Right.
think that's what's happening. Yeah.
Good. Well, we could always use more PTs in there doing wound care because you know it's still very common to be out there talking to a group of nurses or non-therapists, and they're like, "Oh, I didn't know PTs do wound care." You're just like, "Yeah, I've heard that one before." So,
Well, the codes that we use for the billing are really universal codes. They can be used by PTs and nurses.
right,
Yeah,
right, right. All right.
right.
So let's kind of talk about what types of wounds that this can be used with. Is there any limitation to what you can use this your product on?
Well, maybe you're asking the question of contraindications.
Yeah, like
Uh,
that. Yeah.
yeah, well, we really have found that if the patient is fully anticoagulated, and that might mean full heparinization, such as a patient returning from a dialysis treatment,
Okay.
or if the patient is fully anticoagulated for some other reason, you really got to be careful because it can stimulate some bleeding.
Okay.
That being said, the protocol is written so that if the INR is less than 3.0, it's okay to do CPI. That means an INR of 2.5, 2.8, that's fine. But when you get to being fully anticoagulated, which is an INR 3.0, we suggest that you adjust the INR first before you do your CPI treatment.
Okay.
And sometimes that just means wait a day or wait 6 hours so that the heparin is cleared from the patient's system, and then you
Sure.
can irrigate the diabetic foot ulcer or whatever it might be.
Excellent. That makes a whole lot of sense there. Good, 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 good answer. Well, you've got a couple of some case studies, some posters that you wanted to share. So I will pop one up here, and you can kind of just talk a little bit about its background, and we'll kind of go through the ones that you gave me to kind of share with the audience. So I will bring the first one up here.
Bill, thank you for popping that up. This was presented at the Symposium for Advanced Wound Care. We all know it as the SAWC. And this one was in Charlotte, North Carolina. I had the privilege of working with Life Care Centers of America. Maybe there are a few in your audience, but that is a great organization, and I really enjoy my partnership with Life Care. They took the CPI treatment and applied it to venous leg ulcers. So primarily, the purpose of this poster was to show that the closed pulse irrigation system could be used effectively in a subacute nursing facility to change the trajectory of a non-healing wound. And what's significant is this wound was non-healing for 4 years, Bill.
Wow.
So this is a great way to target biofilm in a nursing home, not requiring a full-blown wound care specialist, and it's doing it using a non-invasive technique, which will not make the wound bigger. So it really is amazing when we put it all together as a package.
All right, great. I'm going to pop this one off and bring up another one you had shared with us.
Again, we're using the same technique. And this picture looks a little bit blurry, Bill. I don't know if you have a way to fix that.
I can't. No, I do not. It's
Oh,
on
okay,
my end.
it's
It's pretty
coming
clear.
through. Okay. As far as I know, this is the first application of using the closed pulse irrigation system on elderly burn wound patients. I don't know if you have ever studied it, but elderly people make up a great uh, number of burn patients, and they seem to be ignored, for whatever reason.
Mm-hmm.
And this was a way to bring the burn treatment to the patient in the nursing home. And many of these patients did just beautifully. They tolerated the warm saline. They cleaned up quickly. The risk of burn infection was dropped significantly. You can see there was a buttock wound, which was very difficult to keep clean. But if they used the treatment 5 days a week, just 5 days a week, they were able to get complete secondary healing on that elderly patient. Elderly people also tend to have more comorbidities, so sometimes dealing with diabetics and a burn. This patient at the bottom here is a patient with a third-degree burn to the ear and the helix and the sternocleidomastoid muscle, and you can see just doing this on a daily basis can foster the complete healing.
Excellent, excellent. Let's draw up another one here. I know like you had some really good, neat ones I thought would be fun to share. So.
Okay, you asked earlier about trauma. So this is a trauma patient that a very attractive person who was just happened to be in the wrong place at the wrong time, and she was assaulted. Just coming out of a bathroom in a local bar, and that little incision on her cheek turned into a full-blown MRSA infection. So what I like to describe here is this golf ball type abscess. Whenever you see a large abscess like this, Bill, that's usually an indication that it's MRSA.
Gotcha.
And we were trying to figure out what should we do. Her primary care had put her on antibiotics. It wasn't really working. So I figured we would use the closed pulse irrigation for her just to clean the wound and get adequate wound bed preparation. And it looks like in about 3 weeks we were there. She came to the office during her lunch break at 12 o'clock. She'd show up Monday through Friday. We would irrigate this. It takes about 15 minutes to do the whole thing. And then she'd go back to her work. And we had adequate wound bed preparation so that we could do a quick scar revision and fat grafting. And she's very happy with her results.
Excellent, excellent. Yeah, that looked like a great, great outcome there. Let's see, we had a venous leg ulcer. We already covered that one. Sorry. Here was another one.
Yeah. Well, this is a surgical site infection. The poster child for wound care tends to be the pressure wound, so we all know that. But this, an up and coming number of wounds are really in the surgical site infection category. And this was a patient that had an abdominal incision and a colostomy placed. Once that incision was closed, in a few days it became infected. And she was transferred to us from Florida with a wound vac. Apparently, the wound vac does not remove biofilm, Bill, and that's again that's a subject for another session. But we were able to discontinue the wound vac and just get the closed pulse irrigation going. And with our isolation system, we were able to leave the colostomy bag there. There was no disruption, and after 3 weeks. I'm sorry, 2 weeks of closed pulse irrigation in the nursing home, she went home and completed the rest of her treatment all the way to complete healing.
Wow. Excellent, excellent.
Yeah,
Great
yeah.
information.
And with the water treatment, I'll tell you, you don't have to go poking around in there and debriding with a scissors or a scalpel. And you really don't want to be poking around the abdomen like that. The water will do all of the work. One of the key features that we used in that case was a tunnel tip. So this was able to irrigate in a tunnel.
Got it.
And it was one of the key features of that of healing that abdominal wound.
Yeah, when we were talking too, you mentioned something about the tunnel tip that it provides a 360-degree irrigation stream, so to speak, when you use the tunnel tip.
Right. The standard irrigation is basically something like this, where irrigation fluid is coming straight out.
Right. There you go. Hold it right in front
there
of your
go.
face there, Doc.
Okay.
Now you can see it.
Yeah, I'll put it in front of my face. Now, that is a direct stream outward. The difference here is the stream is coming through perpendicular. Okay, so there you go. And what that'll do is that will cleanse the tunnel as you move this in and out of that tunnel.
Oh, okay. Yeah, that kind of makes a lot of sense. That sounds like it's much more efficient that way.
Yeah, I wish I had a good visual for that, but it's a great tool for tunneling wounds.
I have a question from the audience real quick, since we just kind of covered a bunch of those studies. Are those case studies that we put up with, are those available that if they were to contact you, they could get, copies of those?
Yeah. Yes, most definitely. You can get them through Pulse Care Medical. And I think, Bill, you're going to put some contact information up at the end.
As we get done here, I will put up your contact information so that you can reach out if you want those.
If anyone, you may not know this, but if you go to Wound, WOND, Source, SOURCE, go to their website, they have a poster hall that's set up. And if you put my name in and search it, those posters will pop up at woundsource.com.
All right, great. That's a good. Yeah, I've talked about that. It's a good website. There's a lot of good free information available on there. So, since we talked about what to use it with, let's kind of talk about reimbursement then. When is reimbursement available? Who can bill for it and actually get paid to do the procedure? And so let's start with that.
Well, Bill, I think we're very fortunate in the hydromechanical debridement, selective debridement coding. The code typically is 97597. That's the primary code for hydromechanical debridement, removal of biofilm, and it is a selective debridement.
Sure.
Everybody should be aware that there's an add-on code. So if the wound is greater than 20 centimeters squared, you're going to put a little plus sign and another code, which is 97598.
Correct.
Together, those two codes, the 97597 and the 97598 give you the maximum payable reimbursement for your treatment.
Okay.
And it can be done on a daily basis, which is very different from doing sharps on a weekly basis. So this
Sure.
can be done daily.
Gotcha. Do you any idea what is the rough reimbursement on that code nowadays?
Well, yeah, the rough reimbursement, has been about $100 to 373, depending on your what clinic and what setting you're in.
Sure. Okay. All right. That makes a lot
Yeah.
of sense. All right. Excellent. Excellent. Um, I know that somebody had brought up a question on the one case study using where you stopped doing the wound vac. I think it was the MRSA one on the abdomen, and
Yes.
um, and they had just said, and you did no, you stopped the vac, you just did the CPI system, but
Right.
they had a question if there was any other supplemental treatment, and I assume you were providing, basic wound packing, and dressing changes, stuff like that. So, but you just
Yeah.
basically, from a
Well,
modality perspective, you shifted gears from the vac to just doing CPI. Is that correct?
right. When I show that case, we only use the CPI plus a simple hydrogel, wet to moist dressing. Hydrogel being something that's basically just normal saline, but it's in a gel form.
Okay.
Um, a lot of our providers are now combining this CPI technique with the wound vac.
Okay.
Um, in this particular case, we just followed through with CPI to the end. If we had added the wound vac plus CPI, maybe CPI with every vac change, that would
Mhm.
have been another very viable option for this
Sure.
patient. We just didn't choose to do that.
Okay.
Mhm.
Gotcha.
Yeah,
Gotcha.
yeah,
Now, you had mentioned something when we had chatted yesterday, kind of prepping for tonight's interview, about how well your product works with PDPM. Is there
yeah.
something you wanted to mention in particular for our audience about that particular subject?
Well, PDPM is our newest healthcare uh, transformation. We've sort of evolved into this PDPM for us to really focus on cost effectiveness.
Right.
It's hard for us to make a shift to cost effectiveness because we're well entrenched in just spending as much money as we can.
More money
But
makes it
what
heal
we
faster,
found,
Doc. Didn't you know that?
yeah, heal faster. Yeah. If it's more expensive, it must be better.
It must be
But
better. Yep.
what we found is that the most expensive wound care treatment in the world is the one that's not working. Okay, let me
That's
repeat that.
priceless. I'm gonna quote you the first time, and then I'm taking that as mine.
Okay, I will let me repeat that. If your wound care modality is not working and you're doing it for 4 years, that's very expensive. So let's all think about this. If we target the biofilm, which is for me, it's been our focus, and we get the wound on a healing trajectory, that will be saving money in the long run.
Sure.
Right,
Makes a lot of
right.
sense. And I know we
So
just touched on it, and I know you don't have it because it's still too new, but you were saying that there's obviously some potentially benefits in with the new PDGM in home care. Too early to tell exactly what that's going to be,
yeah,
but any thoughts you want to just share on that from
well,
your
I
background
I
and your experience?
yeah, our experience is that the PDPM model is going to translate itself into the PDGM for home care, and I can't really comment on it. I don't think we really have enough hands-on experience right now, but we're
Sure.
anticipating that this PDGM is going to be um, something that's going to redirect the home care field so that they're focusing on healing faster and better all at the same time. And I do believe that the CPI treatment can get you healing faster, with the targeting of the biofilm,
Mm-hmm.
and better because we're not making the wound bigger in order to make it cleaner. So there's a lot of benefits. We're not sure where PDGM is going to end up.
Okay, excellent.
Yeah,
So
yeah.
now for the real question, okay? Put you right on the spot a little bit. Why would a clinician choose your technology over other irrigation products on the market?
Well, we are the only self-contained pressurized irrigation, unit in the, I can't say in the world, but
Sure.
in the United States. Our company, Pulse Care Medical, came up with this idea, and we have the largest amount of experience. Thousands of cases. We've dealt with the physical therapists, the occupational therapists, the nurses, the doctors. We've seen it all, done it all, and we've got a great support team that can answer your questions, your clinical questions. We've accumulated a great pulse care library of clinicals. So when it comes to applying the no suction, no touch closed system to any type of wound, I think we've got the experience to guide the providers with this new technology.
Excellent, excellent, excellent.
Yeah.
Now, I know we talked about this before we came online. Did you want to take a few minutes and kind of show a demo of the product? You have it kind of set up in the background there. Do you want to take a few minutes to do that?
I thought you might ask that question, Bill. And if anyone's interested, I'll get going with this. It's right behind me here.
Yeah, you just got to adjust your camera there for us, Doc, so we can see it.
Okay.
Other way. I think you got to go the other direction. There we go.
Yeah.
And tip it down a little bit. There we go. A little more if you
Okay. Now
can.
you're getting warm. Well, what you have is a system that comes packaged individually, and what the practitioner would do is set the patient up at the bedside, bring the patient a little bit closer to the edge of the bed. Right now, it's on a conference room table. With this setup, you have also an irrigation unit. Okay, and this is preset for the 15 psi that we're talking about.
Okay.
And it is adjustable so that if your patient is having some discomfort, you can back off on the pressure. Once this is set up with a 3-liter bag of irrigation quality normal saline, what we would do is apply the collection system to the patient. So remember, we talked about taking the operating room to the patient. Basically, that's what this is. It's a 15 centimeter opening by 10 centimeter opening. The nurse is going to open up the adhesive so that it's exposed. Maybe with a little skin prep, you're going to take the Pulse Care device and apply it to the patient.
Okay.
It's an FDA approved adhesive. And what we've done in a matter of minutes is we've set up now a complete isolation field for this treatment. And I'm able to take the unit, and this is all done at the bedside or in the clinic. We're able to take the unit, push it through a sleeve. Okay, and that's now performing pulse lavage.
Gotcha. And there's no risk of it spraying back in your face, right? Excellent. That is awesome.
This will come off and allow for the a little bit of the treatment to be used for the tunneling. So you could go back through. And you know, Bill, during COVID, we've had a lot of interest because the primary problem with pulse lavage has been aerosolization, or the spread of micro droplets.
Sure.
We have, this system here can completely eliminate micro droplet aerosolization.
Excellent. Beautiful.
It's amazing how fast it is. This 3-liter bag can be irrigated at 15 psi in a matter of 7 minutes at the bedside.
Excellent.
Yeah, 7 minutes.
Well, we appreciate the demo, Doc. That was awesome, and it's just kind of cool how simple it is. It's not even that complicated to do. A guy like me can figure this out.
This is a solidifier that takes the whole. This would, in a real life situation, this would be contaminated fluid.
Sure. Right. Okay.
And this is where you want to be very, very safe. You see, what happens is this fluid is turned into a baby diaper. It's just like a baby diaper.
Gotcha.
And
all right.
It's binding the pathogens so that everything is safe and well contained for disposal.
Very nice. Excellent. That is awesome, Doc.
There is a different model set up just for leg ulcers, and then we have customization that can be performed. So it's quite a versatile technique when it comes to these containment systems.
Sure, excellent, awesome. If you want to readjust your camera, we can kind of start to wrap things up here. And again, you said that it's automatically set at 15 psi's, correct?
Right.
And you can turn it down how low? What's the lowest setting it can go to?
The lowest that we've been able to detect is 8 psi. Okay. So you can go from 8 to 9, 10, 11, all the way up to 15.
Yep. Excellent, excellent. Perfect, perfect. Well, I guess, hang on a second here. Got another question just popped up. What is a typical patient report during the therapy as far as like sensation or feeling goes?
Yes. We've had some other hospitals do studies on pain levels, and they find that this closed pulse irrigation, because it's a no touch, no suction, is less painful than regular pulse lavage that we all know about. So we're on the track to making it less and less just uncomfortable for patients when they do this. Usually, if there's some discomfort, it could be handled with a Tylenol or a Vicodin, but never any heavy sedation.
Okay, that's nice. That's very nice.
Yeah, that is nice. Yeah.
Well, if anybody's got any last questions out there, please throw them in real quick for Dr. Marasco. I want to just give you one more opportunity, Doc, to share anything that we haven't covered. If there's anything you want to point out that's important that you want our audience to hear and know about closed pressure irrigation, pulse care, here's kind of your last chance to say things up as we begin to kind of wrap things up.
Well, Bill, thank you again for this whole opportunity. I've thoroughly enjoyed this evening with you and your audience.
Well, thank you.
We talked about, just to summarize, number one, let's start targeting the biofilm on wound surfaces. Number two, let's think about using pressurized water as the new scalpel, or as a way of accomplishing debridement. Number three, we've learned that you do not need added qualifications in sharps in order to get this closed pulse irrigation going. So my greatest hope is that this technique will give greater patient access to debridement.
Sure.
And the reason I believe in it is because debridement is the first step to getting this wound to heal. And so if we can get more people doing it, I think we're going to have more patients heal.
Yep.
Quicker.
I agree. I mean, I think we can both agree that people that can do sharp debridement well and
Yeah,
effectively is not, there's not that many clinicians out there that can do it. I mean, that's why, Denise, my wife, and I, I've spent the last 17 years training clinicians how to do it properly, safely, and
yeah,
effectively. But that doesn't
yeah.
mean, I mean, there's far more people out there. I can look back at the number of people I've trained in all my years of doing it, and I don't even scratch the surface of the number of clinicians that are doing wound care, you know?
Right,
So,
right. Right. I believe that access to debridement will decrease some of the complications that we see in wound care, such as wound sepsis and,
right.
readmissions to the hospital. I hopefully, by having more frequent hydro debridement in conjunction with sharps, because I
Sure.
don't I don't criticize sharps at all.
Sure.
After all, I am a surgeon, Bill.
Yeah.
So, you know, we have to have sharps, but to complement it with a daily debridement so that the wound does not get out of control. Right.
Amen. I am with you that 100%. Well, I want to put up your contact information so you can review this for the audience here as we start to wrap things up, Doc.
Yep. Thank you.
Yep. So if anybody wants to reach Dr. Marasco, here is the info if you want to take a quick screenshot. Otherwise, like I said, you can also go back and watch this video again. It will be available on our Facebook page as well as our YouTube channel. So you can always go back and skim to the end of it so that you can write down or screenshot this information. As Dr. Marasco said, if you're interested in those case studies, you can certainly go to their website or email them, and I'm sure they can get that information to you. So with that being said, Dr. Marasco, thank you so much for your time. I know you're a busy man. I always appreciate physicians that have embraced wound care, modern wound care. let me emphasize modern wound care, not what I like to refer to as what do I commonly call them? Having a fact check. 16th century wound care. So I really appreciate the knowledge you shared. This is an incredible product. I mean, personally, myself, I've never used it. I'm familiar with it. I've seen it on the internet. I've seen, I believe, that at booths at some of the conferences. So I'm really excited that I had the opportunity to get you on here live and share your vast knowledge with our audience. And I think that, embracing a modality like this will certainly go out and change people's lives. So thank you again. I certainly do appreciate your time this evening, Dr. Marasco.
Thank you, Bill, and thank you to your audience.
All
Thank you
right.
very
You
much.
take care, sir. We will talk again. I'm sure we'll have you back on sometime in the future.
You're very welcome.
All right. Good
Thanks.
night now, sir.
Good night.
Well, that's it for tonight, everybody. I want to thank everybody who tuned in. Thanks for all the great comments and the questions. Those were awesome. Again, this video will be available for replay. So share it with your friends, your colleagues, or refer them directly, of course, to our YouTube channel as well, too, where these will be uploaded. And those will be available tomorrow, probably at the latest, if people want to watch it on our YouTube channel as well, too. So I want to appreciate everybody's time and tuning in tonight with us. And with that, everybody, that's a wrap. We will see you next time on Wound Care Gurus Facebook Live.